Hello, it's nice to see you all this evening. My name's Carol Reed, and I work here in the town of Needham in the Public Health Division for Tim McDonald, the Director of Health and Human Services. I've been in Needham since 2008, and I just want to take an opportunity to thank our town manager, Kate Fitzpatrick, who, since I started here, has been a huge champion of the prevention work that we're committed to in Needham. So we appreciate being here tonight, and I want to make sure I thank Mark Mandel, the Executive Director of Needham Cable, who is live streaming our event. So welcome to all those who are watching through their computer. We appreciate it. And Mark will also be preparing a program that all of our communities can share of this whole forum. So we appreciate him. I just want to let you know that there are some refreshments. It's a warm and beautiful night, so please welcome for water or something to eat. And if you'd like to use the restroom, it's out here to the left. And we're just grateful to have these amazing speakers. You know, April is Alcohol Awareness Month, and one of the gifts that I feel of working in this field in Massachusetts is being able to be surrounded by experts like Dr. John Kelley and Liz Parsons, who's working now doing work for the CDC in U.S. alcohol policy, Dr. David Jernigan, BU School of Public Health, and Dr. Amy Turncliff, a neuroscientist. So my colleagues here, as we know over the years, have been really grateful to have these experts and work for our coalitions, for our public health departments, in sharing information to enhance the health and safety of our communities. So I will thank you again, pass the microphone to Tim, and for the rest of the evening I will just be facilitating the computer. So thank you so much. It meant the world to us to plan this event and have you here. Tim?
Thank you, Carol. Carol did a little bit of my job for me in mentioning the names of all of our speakers. I'm going to tell you a little bit more about their bios, but I wanted to talk a little bit about why this is relevant or how this is relevant in Needham. So Carol mentioned the Alcohol Awareness Month. We had in the town a ballot question on Tuesday, which unfortunately passed, but was about expanding access to alcohol, additional licenses that would be given out in town. The Board of Health voiced sort of strong opposition in the community, talked about how increasing alcohol availability in the community leads to increased use, increased alcohol outlet density leads to increased use. Unfortunately, that argument was not persuasive to the full majority of the town, but it is something that I was proud that our Board of Health did, and it was something I was proud that our Substance Use Prevention Coalition did. One of the things that Needham has done is, and it's relatively unusual, we had a 10-year federal grant, a federal drug-free community grant, which is a major jumpstart for any community that wants to do substance use prevention. But Needham's grant expired, and the town stepped up and actually funded in whole a full-time staff person, a part-time staff person, and all of the money we put into contracts and graphic designs and events. It was a tremendous commitment, and it's something that Needham has done repeatedly. We've been fortunate as we built a team of folks that work in substance use prevention to get other grants. We have a federal SAMHSA STOP grant right now. We have a Mass Call 3 grant from the Bureau of Substance Addiction Services at the Mass Department of Public Health. We've been very fortunate to build up a team of public health prevention professionals. And so even though there is expanded access to alcohol in Needham, the Public Health Division and the Board of Health will continue to push, we'll continue to push the town and the Select Board to take alcohol compliance seriously. The Board of Health takes its role in tobacco compliance very seriously. The Board of Health takes its role in tobacco compliance very seriously. We do semi-annual inspections, we do quarterly compliance checks, we have very stringent tobacco regulations, as most folks know, and we always like to brag about this in Needham. Needham was the first community in the country to adopt the Tobacco 21 rule, which raised the purchase age for cigarettes. The Board of Health in alcohol compliance, it's a little bit more complicated. The Board of Health doesn't have the complete subject under its control, but it is interested and willing. It's an important part of public health, and so the Board of Health and the Public Health Division are continuing to work with the Select Board and the Town Manager about how we can take alcohol compliance in the community more seriously. Karen can correct me if I was wrong, but our previous compliance check, there was 11 sales out of 27 outlets. There was a check done last night, and there were 2 sales. So if nothing else, that's progress. I'm going to jump sort of into introducing our speakers because you came to hear them and not me. But we have a distinguished panel today. Starting at your far left, my far right, is Amy Turncliff, who's a neuroscientist and a public health advocate, and the founding director of Rockfern Scientific Consulting. Amy obtained her PhD from UNC Chapel Hill and completed her postdoc training at Harvard Medical School. Has been active in substance use prevention and community coalition building for years. Co-founder and chair of the Metro West Substance Awareness and Prevention Alliance, and an active member of the I Decide development team, which is a collaboration between, and you'll hear more about the Center for Addiction Medicine at Mass General later, the Massachusetts Department of Health and the Institute for Health Recovery. So I Decide. Dr. John Kelley, which is why you're going to hear more about the Center for Addiction Medicine, is the Elizabeth Spallin Professor of Psychiatry and Addiction at Harvard Medical School, which is the first endowed professorship in addiction medicine at Harvard, which is great. He's the founder and director of Recovery Research Institute at MGH, the associate director of the Center for Addiction Medicine, and the program director at ARMS, the Addiction Recovery Management Service. Dr. Kelley is extensively published and has consulted for U.S. federal government agencies and the WHO. We have Dr. David Jernigan. He released a fascinating report, and we have copies actually at the back, on alcohol policy in Massachusetts. But he's the professor in the Department of Health Law, Policy and Management and the assistant dean for public health practice at the BU School of Public Health. He's a senior advisor to City Health, which is a really fascinating program from the de Beaumont Foundation and Kaiser Permanente. And you previously directed CAMI, which is the Center for Alcohol Marketing and Youth at Johns Hopkins. And last but certainly not least, we have Liz Parsons, who's the chair of the Massachusetts Alcohol Policy Coalition and associate director of the Center for Advancing Alcohol Science to Practice. Liz has worked, and this is how I met her, in community coalitions for years. She's been an advisor to multiple communities that have been developing or starting their community substance use prevention coalitions, and she's been doing that for almost 2 decades. What's that?
Make you sound old.
She's been doing that for only 2 decades? I don't know. I'm not sure. Certainly was not my intent. We have a very talented panel, and I hope you'll listen to their presentations, and we'll have time afterwards for some questions and some discussion. Thank you. So Amy Turncliff is our first speaker. You want to do the?
Figure out.
Thank you to Tim, Carol, and the rest of their team for the invitation to speak tonight. And I think you got a pretty good bio from Tim, but I think probably among the most important pieces of my bio is that I'm a mom to 3 kids. They are 16, 14, and 11. So for those of you who are parents, grandparents raising your grandchildren, I am right in the thick of it with you right now. So we're in fun times, aren't we? Let's see. So I wanted to have a fancy first slide. So I get to give you a crash course in neuroscience to start off. So I hope that's really exciting to you. It's exciting to me. And oftentimes there's a lot of negative kind of connotations that go along with discussion of the teens and tweens. But it's really an exciting time, an exciting developmental time. I hope you'll feel that way after I speak. And then what does introducing alcohol into the teen brain actually do? Why does it matter if they experiment? It's a rite of passage we often hear. But what are the consequences of that? And then if I have time, I'll talk a little bit about that teen alcohol use is not inevitable, and that addiction is preventable, and that we really need to start as early as we possibly can to have that conversation. So really the process of development I look at as training the brain. So we, as adults in the lives of young people, are helping our young people, our children, our grandchildren, to train their brains. And that's kind of the process of the environment is shaping them and through shaping their brains. So the basic neuroscience, which is really exciting, is that there's neurons in the brain. There are actually many different cell types in the brain, but the neuron is the one that we think of most frequently when we talk about the brain. And so there's a cell body, which is right here. And the cell body is kind of the powerhouse of the cell, has the nucleus, and then there are dendrites, you can see there. And those are kind of receive messages from other neurons. And the axon carries the message, and oftentimes that's an electrical signal. And then the synapse is where the axon terminal of one neuron kind of talks to the next neuron via the dendrites. And that's a really simplified kind of description of what happens. But oftentimes there's chemical messengers in the synapse that then carry information from one neuron to the next. And oftentimes always, there are many kind of neurons talking to each other in a synapse. So a little picture, there's an electrical message carrying information into the synapse, and then information is communicated across the synapse to the next neuron. Really basic. And here is a blow-up of the synapse, the meeting point between two neurons, and that's the signal coming into the axon terminal, and with vesicles that hold neurotransmitter in the terminal. And then this would be kind of the dendrite of the next neuron. And this is an example of the neurotransmitter releasing from the vesicles of an axon terminal into the synapse in here, and then being communicated to the signal is communicated to the next neuron here through receptors. And so there are many different kinds of neurotransmitters and many receptors that bind to those neurotransmitters. So I wanted to just give an idea of, this is a very complex system. There are many, many proteins, many kinds of receptors, many kinds of neurotransmitters in the same cell and coming across in the synapse. So that's just the basics of neuroscience. And then what happens during neurodevelopment? And there are, all kinds of changes that are taking place in the teen brain. So I like to think of it as an amazing time of opportunity. Yes, brains are, we often hear the teen brain is very vulnerable, teens make bad decisions, but try to maintain the perspective that their brains are really going through a process of neurodevelopment that we outwardly see kind of the consequence of. So by age 11 for girls and 12 for boys, the neurons in the front of the brain have formed thousands of new connections. And then over the next few years, most of the connections will be kind of pruned away. And what happens is that pruning that happens is based on which kind of neurons are talking to each other, which synapses are most active, and those that are not used will kind of be pruned away, and those that are used will be solidified and kept. This is kind of the depiction of early childhood, and then early adolescence, and late adolescence. So in early childhood, you have kind of neurogenesis, you have connections being formed. Early adolescence, you have kind of what we think of often depicted as a tangled mess. And then as the neurodevelopmental process takes place with that pruning, then you kind of have something that is more organized, right? You have the process. So for example, if you were to use music or sports, we often hear the more you practice, the better you get. And that's kind of a process of, an example of the process of how repetition and the connections that are most used are solidified and kept, using the use it or lose it principle. So this process of neurodevelopment and maturation occurs from the back of the brain to the front of the brain over time. So at the back of the brain, that's where you have maturation occurring first, and then over time, as our young people age, the brain matures towards the front. So what does this mean? What does this look like? So the first part of the brain, at the back of the brain, it's the first to develop, is really thought of, it's a hindbrain. It's thought of as the primitive brain. These are really where the brain structures that are responsible for basic life support. So breathing, heart rate, heartbeat. So all of those kind of basic life processes are found at the back of the brain. And so those mature first. Oh, going the wrong way. And then the second would be the subcortical midbrain, which we often just call the emotional brain. So these are kind of the brain reward pathway, emotional kind of processes. And these mature before the rational part of the brain, right? Which we often, if you hear about the prefrontal cortex, executive functioning. So, our young people are kind of programmed to experience reward and sensation seeking, right? And risk taking, so that they will leave home. They won't stay and live with us forever. So evolutionarily, there's a reason for this. And I try to remind myself, when my 16-year-old is pushing my buttons, that this is part of her process so that she doesn't want to stay and live with us forever. Because if she had a fully functioning rational part of her brain, she may choose to stay home with us forever. And so now the prefrontal cortex, or the forebrain area here, is thought to continue to develop until 25 or even 30. So to summarize, the adolescent brains are building superhighways for the pathways used regularly. The centers for logic and reasoning are still developing, and the reward system is particularly active in the teen brain. So I'm going to switch to talk about the impact of alcohol and what happens here. So this is the ethanol molecule, and I think it's helpful to think that when we ingest, or our teens ingest, alcohol or other drugs, you're taking something in, it's moving throughout the body, goes to the brain. I think oftentimes adults maybe ingest something and don't think about what that actually means and what's happening. So if you think about the kind of the basic, neuroscience that I mentioned at the very beginning, and then you add kind of ethanol into that, you've now got alcohol or ethanol in the synapses, right, in the brain, and interacting with receptors in the brain, sometimes competing with neurotransmitter for the receptor, or changing the way in which the receptor responds to its natural neurotransmitter. So what happens to the parts of the brain I just mentioned to you that are developing, right? So I'm actually starting with the last to develop here. So this is the prefrontal cortex that I showed you develops last. So if you add alcohol into the brain, you have reduced inhibitions, reduced ability to plan and prioritize, and reduced behavioral control, right? This is the part of the brain that's responsible, as I mentioned, for impulse control, planning, again, executive functions. So if you have alcohol in that subcortical midbrain, the emotional part of the brain, you have reduced emotional control, impaired memory function, and increased dopamine in the reward pathways, which is that kind of feel-good aspect to using alcohol or other drugs. And then alcohol overdose can occur, and it's this area at the hindbrain or the primitive brain portion where that occurs. So you can have reduced coordination, that's the cerebellum, and then slowed breathing and slowed heart rate would be a consequence of ingesting too much alcohol, and that the impact on that part of the brain. So in terms of functionality, what does this mean? What would you observe, right, in daily life, or what would be the consequence for teens who were heavy drinkers, in particular for this slide? And there have been imaging studies done, and this shows a functional MRI image. On the left is a 15-year-old male non-drinker, and on the right is a 15-year-old heavy drinker who was sober at the time, who was not impaired at the time. You can see this individual was performing a memory task. You can see there are differences in brain activity between the 15-year-old non-drinker and the 15-year-old heavy drinker. And this, again, is a memory task. Alcohol use in high school is associated with lower academic achievement, and I have the citation at the bottom of the slide if anyone is interested. This shows this bar here are non-drinkers. This bar here in the middle are current drinkers who did not binge drink, which would be 5 drinks for males, 4 drinks for females, and then current drinkers who do binge drink. So you can see here that as, it's kind of a dose response. The binge drinkers are more likely than non-drinkers to have mostly D's or F's. So it's just an association, again, not causation, but as one might expect, those who partake in more alcohol during high school would have poorer academic outcomes. This is binge drinking in high school is associated with the increased odds of other risky behaviors. So this is kind of a messy graphic, but these circles here are current drinkers who did not binge drink, and then the rectangles are current drinkers who did binge drink. And there's about a twofold increase in the odds of risky behaviors, engaging in risky behaviors for current drinkers who did not binge drink. But you can see the risk increases significantly or substantially for current drinkers who did binge drink. And I think it's probably hard to see all of these risky behaviors, but they include rode with a driver who had been drinking alcohol, currently sexually active, no condom used during last sexual intercourse, physical fight, dating violence, so many of the risky behaviors that we actually measure on the Metro West Adolescent Health Survey. And then this is a graphic showing alcohol use in 7th grade is associated with problem substance use behaviors later in life. I think you'll probably hear age of first use is an indicator of later problem substance use behavior. This shows problem behaviors in 12th grade on the left and problem behaviors at age 23. And this is, the green bars are 7th grade drinkers, the red bars are 7th grade experimenters, and then the blue bars are 7th grade non-drinkers. And you can see that the non-drinkers are less likely to engage in risky, at 7th grade, are less likely to engage in substance use behaviors later in life. I'm not going to go through all of these. This is from the CDC alcohol fact sheet, and I think I provided it to Carol. But overall, youth who drink alcohol are more likely to experience negative outcomes and engage in other risky behaviors. And adolescent brains are more vulnerable to the negative effects of alcohol on memory and learning than adult brains are. And use of alcohol during adolescence may alter brain development, potentially resulting in long-lasting changes in brain structure and function. It's very hard for me to give a presentation about brain development without including a prevention piece, because I am very passionate about prevention. I spent a lot of my career focused on mental health and substance use treatment and finding new treatments. But when I learned about prevention, it kind of was the end of that. So let's think Dr. Kelley will speak more about this, but 9 out of 10 individuals with substance use problems started using alcohol or other drugs by the age of 18. So addiction really oftentimes is considered a pediatric disease of the brain because it often starts during the teen years and in adolescence. So I think from my perspective, it's really important to prioritize behavioral health promotion. So positive mental health, really focusing on mental health, coping skills, et cetera, and prevention so that we can prevent folks from entering into the treatment and need for treatment and recovery, which are also extremely important, obviously. And for every dollar spent on prevention, it's thought that you save about $10 down the line. So 3 big contributors to youth substance use are increased access and availability, the decrease in the perceived harmfulness of a substance, and then social norms that support substance use in your community. So Tim was talking about policies. Policies are extremely important. Policies in the community in which you live, your young people are growing up, and also state, nationwide, et cetera, et cetera. So healthy risk-taking by teens is necessary for proper brain development. We just talked about that. They need to leave the nest. But substance use is not inevitable. It is preventable. I think oftentimes we just have to help our young people find healthy outlets for their desire to take risks. And I really do believe that we all have a role to play and a shared responsibility to support positive youth development and prevent teen alcohol and other drug use. I love this quote by Jeff Linkenbach: "If we want health, we must promote health." Thank you.
Thank you. Dr. Kelley, you are next. Oh, I jumped up here.
Fantastic. Amy, thank you for that really great start. I'm delighted to be here. I'm John Kelley, it's great to be back at Needham, this beautiful venue in Needham. Thank you, Carol, for the invitation and opportunity to be part of the proceedings. I was telling Carol earlier that I'm moving offices down in Boston at MGH, and so I was going through stuff, throwing things away, sneezing a lot with all the dust. And then I came across a CD, funnily enough, ironically, with Carol Reed's name on it from 2014. It was the proceedings from I think it was the 3rd or 4th annual Needham Substance Use Prevention Coalition. And what a coincidence, there it was, wow, and I was coming here tonight. But I'm also struck, of course, at Carol's tenacity and persistence, and people like Carol who don't give up, Lynn, Frano, and others who are here. Just fantastic, champions. We need these champions. We need people like you who are champions, steadfast, committed, who are out for to help with public health and promote it. So thank you.
Thank you, Dr.
Thank you, and thank you for all those and the team members that I've met tonight. It's just an honor for me to be here. I'm very honored to be a part of the proceedings. Like I said, I truly mean that. I'm always ready and willing to come and talk about these issues which affect so much of our daily lives and society as a whole. So I'm delighted to be here with such distinguished panelists as well. So thanks again for having me. So the title of my talk tonight, Alcohol, Man's Oldest Friend and Oldest Enemy. And related to that, of course, it's ambiguous, this ambiguous molecule that we talk about with alcohol. It's also the world's favorite drug. I'll touch on that. I'll talk about the different pathways through which alcohol causes harm, development and risk, and then treatment and recovery. I'll touch on that too. Here it is. This is what it looks like, up close and personal. The alcohol molecule looks like a kind of a well-groomed poodle. well-manicured poodle. And it does have, think about man's oldest friend and oldest enemy. A dog, of course, is man's best friend, right? But it also has a bite and a bark. Again, this is what makes it the ambiguous molecule. When this molecule reaches the human brain, as Amy nicely elucidated for us, it's generally perceived as good news. Generally perceived as good news when it reaches the human brain. This is why it is the world's favorite drug. We don't often call it a drug, even though, of course, it is, and that's something that I'll touch on. But also, there's a very powerful bias with drugs, any drug, including alcohol, that has that immediate, potent, predictable response. Immediate, potent, predictable, very important aspects to any drug. This is why they have such allure, that they can produce very pleasant effects: anxiety reduction, sedation, psychological escape, all the things that human beings tend to like, that can be produced consistently, predictably, and potently in a quick way. And this is what produces a bias in drug taking. On the other hand, the elements of recovery are generally delayed, diffuse, and variable. So this makes it biased towards this immediacy. It's complicated, as they say. It's complicated when we think about, and David's going to talk a lot about kind of the policy aspects of this and why we have a tug of war, why it's kind of, we've got this complex challenge that we're faced with, not just with alcohol, but with all substances. I love this quote by Henry Mencken: for every complex problem, there is a solution that is clear, simple, and wrong, right? All you got to do is X, or all you got to do is Y. If only we did this, then everything would be okay. How many times have we heard that with regards to any drug policy, including alcohol? If it was legal or if it was illegal, if we jacked up the price, if we reduced access, we would solve the problem. Well, it is complicated, it's complex, and this is a nice graphic from the Canadian Drug Policy Coalition, which really highlights different policy positions along the bottom, from prohibition to unrestricted commercial use, and the different kinds of consequences that go along with different kinds of policies. You can see with prohibition, we get the black market, we get cartel crime, and all the things we normally associate with the illegal black market, which, as you can see on the vertical axis here, this is the degree of health and social problems related to those different policies. So if we only made it legal, therefore, if we got rid of the illegality, this is an argument, and if we made things legal, then that would solve our problems. And we could, like we've done with cannabis, right, with marijuana, we make it legal, commercialize it, and everything will be okay. Except it's not. Look what we've done with tobacco and alcohol. Those are both legal, they're commercialized. Right, so largely unrestricted commercialization of alcohol, advertising, targeting in particular young people, of course, and we see very large amounts of harm as well related to tobacco and alcohol. 140,000 deaths from alcohol every year, 400,000 from tobacco. And of course, there are measures now that have been taken with tobacco in particular, which I'll touch on. But there are some sweet spots. You can see here in the middle, maybe there's some sweet spots with different policy positions which can reduce the level of harm. But the question is, with every policy position, who are the casualties going to be? How many? What's the nature of the casualties? We might change who the casualties are, but there inevitably were going to be casualties. That's the thing to think about. We know there are a lot of casualties, of course, with alcohol. So it's complicated. As I said, we've got a lot of alcohol is embedded in our culture in most Western societies for millennia. These are some of the common things that we hear around alcohol. Drugs, quote-unquote drugs, are bad, but alcohol is good, or even good for you. Right? Maybe it's actually helps you live longer. Alcohol is not as bad as other drugs, otherwise why would it be legal? If it is a drug, right? Which is, we don't often talk about it or think about it. We talk about alcohol and drugs. Young people are going to do it anyway, so, we should just kind of minimize the harm because they're just going to do it, as Amy was alluding to. And we all know that alcohol prohibition doesn't work, so what's the point of that? In fact, it made things worse. How true is that? These are the kind of common things that we hear. And these are some of the pictures, of course, that are associated with why it's embedded in most societies. The world's favorite drug. It facilitates all of this disinhibition, anxiety reduction. It helps in social situations. So it's very common. And again, it's generally perceived as good news when it hits the brain. And this is the picture we would like to see and believe is true. But there's also, of course, another side to alcohol and alcohol addiction, and also violence, which comes along with it. It's not just the person themselves that are affected, but also people around them. Oftentimes, the kind of what they call the externalities of the impact of intoxication. As I alluded to, there's 140,000 deaths. These casualties tend to be absorbed into the social fabric in our society. This is not headline news. I don't know if you've heard this statistic lately on NPR or CNN. I don't think so. Because we're so inured to these casualties that they are never headline news. In fact, when you talk about this, if you were to say to people, do you know there's 40% more deaths from alcohol than there is from opioid overdose? No. Really? Yeah. But we're just not used to talking about it. In fact, we're so used to these casualties that they're no longer headline news at all. That's about 400 people a day dying from alcohol. Now, alcohol, when we think about alcohol and alcohol use disorder, that's kind of where I'm at in my work. I treat a lot of people with alcohol addiction, other drug addiction too. But it's very important to remember, I think, that alcohol causes harms not just through alcohol use disorder or alcohol addiction or alcoholism, as the old term for it, but also through these other pathways of intoxication and toxicity. So, for example, you do not need to be addicted to alcohol to become intoxicated, psychologically impaired, and fall down the stairs and break your neck and die. Or drive your car, kill yourself, kill somebody else because you're psychologically impaired through intoxication. Now, those intoxication, of course, happens more often when you're addicted. But it's an independent but related pathway through which substances cause harm. Toxicity is another one. It's one we don't often think about. Toxicity, for example, can increase the risk of chronic disease, like alcohol-related liver disease, for example, alcohol cirrhosis, also cancer. In fact, half of alcohol-related liver disease cases, people don't even meet criteria for alcohol addiction because you have to use for a long period. Most people who have florid symptoms of alcohol addiction tend to either be dead, locked up, or sober before they get to that alcohol toxicity, alcohol-related liver disease stage. It's a different type of alcohol-related illness that usually comes around through toxicity. Cancer is another one. And again, when we think about the 60 different types of diseases which are associated with alcohol, I don't think many of us would think about cancer. I think we normally would say tobacco smoke. Yeah, tobacco smoke is level 1 carcinogen. But did you know also that alcohol is a level 1 carcinogen? It's in the same category as asbestos and tobacco smoke. It increases risk of cancer at low, consistent levels, at low dose levels. Just 20 grams of alcohol, that's less than 1 1/4 drinks a day, for a woman, increases breast cancer risk by 12 to 20% relative to women who don't drink. It increases esophageal cancer risk by 86%. Just 20 grams a day. That's less than 1 1/2 drinks a day, increases esophageal cancer risk by 86% relative to people who don't drink. So that consistent low-dose exposure doesn't have to be very much, but just consistent over time can elevate risk of cancer. Now, not many people know this, not many primary care physicians know that, or even communicate that to their patients who are at risk for these kinds of illnesses. There's also a lot of confusion, as I mentioned, around, well, is it good for you? We heard a lot of things in the media about alcohol. Maybe it's good, it's had a cardioprotective effect maybe, and it can maybe prolong life. Maybe it's good for you. And you see people chugging back wine, right? A red wine, saying, well, I've heard this is good for you, isn't it? Doesn't it help you, like reduce the risk of heart attack or heart disease? Or anyway, I heard something vague, so that means I can drink. So, and of course, it's something we want to believe. We'd love to believe that something as enjoyable as alcohol was actually good for us. Turns out it's not. It doesn't actually increase, and this is the latest study, just came out last week, of 107 studies, 5 million people involved in those 107 studies, found that alcohol doesn't actually increase your longevity. It has no effect on it, other than the bad effects. It has no good effects. Also, in terms of death and disability and disease, these studies come out. This one just came out in November. But here in the United States and around the world, it's one of the biggest killers of men of working age. It's the biggest killer worldwide of men of working age, alcohol. Number one. Kills 3.3 million people. That's 10 times more than all drugs combined worldwide. So it is a major national and worldwide killer, particularly among young men of working age and young people. In some states, for example, New Mexico, 1 in 4 deaths between the ages of 15 and 46 are due to alcohol. So this is a big killer, particularly in certain states around the country. When drugs have been compared for their harm, both to the individual and the community and others, alcohol actually comes out top. This has been replicated across different groups of experts and across 20 different drugs, as you can see across the bottom. Alcohol comes out the top in terms of harm to the user as well as harm to others relative to other drugs. Again, that may surprise people when you tell them that. Economically, it has a major drain on economies around the world, including here in the United States, roughly $350 billion we write the check for every single year these days in terms of the economic burden. That is healthcare, criminal justice, and lost productivity. People calling in sick, not going to work, not able to work because of alcohol-related illnesses. Now, there's a lot we can do when we think about the public health model of in this case, substance use, alcohol use. When we think about the agent here, the drug, alcohol, the person, and the environment. And the environment has a major role to play, of course, in what we do. Policies that David's going to talk about. Just huge, massive. Of course, we've seen this with tobacco. We haven't banned tobacco, but it's restricted where you can use it. So the availability, accessibility, and the price, all those 3 major factors which affect consumption of any desirable commodity. When you move those around and you decrease accessibility and availability, in other words, where you can smoke and where you can get cigarettes, and also jack up the price through taxation, huge effect in the population of smoking. More and more people quitting or not starting. Because of those policy changes, big ticket items in terms of producing population level effects. There are other factors at the more individual level, of course, school levels that Amy was alluding to, prevention, as well as early intervention, catching these disorders early for people who are at risk, showing signs and symptoms of the disorder early. For those who manifest the full disorder, of course, there is treatment, continuing care, and remission and recovery. Amy nicely gave us a nice 101 overview of the neuroscience of addiction. Let me just put that into what we see in terms of the phenomenology of it. When you think about the 4 main reasons why people start using alcohol are what? To feel good, to feel better, to do better, performance enhancement, or because other people are doing it. Okay, fair enough, right? Immediate, potent, predictable, good news when it hits the brain. What are the 4 main reasons why people stop using alcohol? To feel good, to feel better, to do better, because others are doing it. What was the best thing ever turns out to be the worst thing ever. The train leaves the station, you're on this fantastic journey, that locomotive picks up speed, it gets out of control, you can't put the brakes on no matter what you do. It's got too much momentum no matter what you try to do. And this is what happens, what we now call neural plasticity. The changes in the brain as a function of this abnormally high level of reward and reinforcement. which comes about as a result of this drug, this potent drug which needs to be taken as Mother Nature adapts in the brain, adapts to these doses. You have to up the dose to get the same effect as you did at a lower dose. So you have to turn up the volume more and more, and that creates more and more change in the brain, both functionally and structurally in the brain through neurotoxicity as well. Amy prefaced this, she alluded to this notion of delay of first use. There are epigenetic effects. This means that if you can delay exposure, this is why, of course, we have, in part, a minimum age for first use of 21. Arguably, that should even be a little bit higher, given what we know about the developing brain. But there's also genetic effects, not just neurotoxic effects, but genes that get turned on that would not get turned on if people are not exposed to neurotoxins. You see here quite clearly the linear relationship between delay of onset of first use and the chances of having a disorder, an alcohol, or in this case, on the right, cannabis use disorder, marijuana disorder. So just 9% chance if your first use is after age 21. 47% chance if your first use is below. You can see the linear relationship quite clearly about delaying first use. This is why we've been advocating, of course, for this notion of prevention of use for these reasons. When we look at the timeline for people who have an addiction to alcohol, this is what it can be like. So when we look at cases who are addicted, it can take a long time for people to get into recovery and to achieve stable remission. On the left-hand side of this graphic, you can see that 4 to 5 years. That's the number of years on average it takes in adult clinical samples after people meet criteria for an alcohol disorder before they start seeking help. So why is that? So part of that, of course, is the attempts to put the brakes on that locomotive, trying to stop the train. They want to get off. They can't. They keep trying. There's a lot of shame. There's a fear of course, discrimination, the fear of stigma that keeps it secret. People don't want to acknowledge it. They don't want to acknowledge it to themselves. They certainly don't want to talk about it with others. But after about 4 to 5 years on average, people will start seeking help. You can see it takes about 8 years after people seek help in adult clinical samples to get 1 year, that first year of remission. Now, most of those days are abstinent days. It takes about usually 4 to 5 treatments on average, or mutual help involvement like AA, before people are able to achieve that first year of full sustained remission. What's also noteworthy from a chronic disease management perspective, if you look on the right-hand side, it takes 5 years, another 5 years after you've got that first year of remission, that first year without symptoms. It takes another 5 years before the risk of meeting criteria in the next year for an alcohol use disorder drops below 15%, which is the annual risk in the general population. So to be no more likely than anybody else in the general population of meeting criteria for the disorder in the following year, if you've already had it, takes 5 years of continuous remission. So this, of course, suggests what? Not just 30 days or 90 days, 12 weeks of treatment, but rather, yes, that too, but also kind of long-term disease management, the way that we might treat diabetes or hypertension. These are good models that match the kind of clinical course for substance use disorder and alcohol use disorder. The question, obviously, is can we speed this up? Well, yes, there are things that we can do, and we know that we can do to speed it up. One of them is early intervention. And this is a nice study by Michael Dennis, which highlights this notion of early intervention. These are people who got into treatment, got some kind of intervention or treatment in the first 9 years after they started using a drug, alcohol or other drug. So if they got some kind of intervention in the first 9 years, they got into remission 8 years earlier than people who did not get any conversation or intervention around their alcohol or other drug use. You can see here the difference in the time it takes. You get into remission 8 years earlier. So in other words, alcohol use disorder responds like other kinds of illnesses to early intervention. The prognosis is better if we can destabilize emerging addiction patterns. We may not see an effect right away. This is why I think sometimes we lose hope in things like screening and brief intervention, because we say, well, we only see small effects. But we're planting seeds. We're planting seeds which come to fruition later. We are destabilizing an emerging addiction pattern which alters the course. Maybe just a few degrees, but over several years, that few degrees has a big difference. In other words, an 8-year difference here. When we think about the stages of change, it's another aspect. I think one of the things that we've learned about how people go through the process of change. This is something that came to light in the 1980s and was explicated by a couple of researchers, James Prochaska and Carlo Di Clemente. What's nice about these stages of change, kind of the pre-contemplative, contemplative, preparation, action, and maintenance, is that we've been able to map different interventions like harm reduction, like motivational interviewing, like cognitive behavioral therapy, like 12-step facilitation and AA participation, to these different stages so we can help people better, more effectively and more efficiently at these different stages. We've also learned when it comes to recovery that there are multiple pathways to recovery. Not everybody needs to go to 30 days of rehab or 90 days of rehab and then go to AA for the rest of their life. Many people do, and they recover, and they have positive lives. But not everybody does that or needs to do that. There are multiple pathways. And we've got now an array of treatments, evidence-based treatments, both behavioral, psychological, and pharmacological for alcohol use disorder. We have 3 FDA-approved medications for alcohol use disorder. Camprosate naltrexone, an injectable naltrexone formulation, and disulfiram antabuse has been around since 1947. We've got new pharmacological treatments as well as behavioral treatments and screening protocols, brief intervention, as well as mutual help. And now we've clarified also the power of peers, the power of people with lived experience. This is a meta-analysis that we conducted on Alcoholics Anonymous and 12-step treatment. What we found in this Cochrane system review, which is considered to be the highest scientific standard for systematic reviews in the world, it's the place where governments and healthcare systems go to look at the evidence. When we looked at the evidence and subjected Alcoholics Anonymous and 12-step treatment, which are clinical treatments designed to link patients to AA, when we subjected those to the same scientific standards as we would any other intervention, what we found is that over 3 years of follow-up, patients randomly assigned to be linked to Alcoholics Anonymous who had severe alcohol addiction had 20 to 60 higher rates of remission over 3 years relative to patients who were randomly assigned to other interventions like cognitive behavioral therapy. Now, why is that? It also had a massive cost savings. So when we link patients to free, ubiquitous, indigenous community support services, which are available, accessible, flexible, low or no cost, we help sustain remission. People don't go to the emergency room. They're not spending overnight stays in the hospital. They're also using psychological services less because they're relying on peers for those benefits. We found that we're saving $10 to $15 billion alone in the United States in 2018 dollars when we link patients to AA with severe alcohol addiction. How does that work? Why does it work? Because it mobilizes the same kinds of therapeutic factors which are mobilized by our professional treatments, but AA does this over the long term in the communities in which people live. And it's very ubiquitous. Within a 45-minute drive of my office in Boston, there's 2,000 AA meetings a week. That's just AA. Okay. Now, we have a variety now of mutual help groups, not just AA. We've got other ones for other drug disorders, of course, Cocaine Anonymous, there's Marijuana Anonymous, there's Narcotics Anonymous. But there's also different flavors, not just 12-step. There's a whole now menu of other kinds of mutual help organizations modeled, inspired by, or in opposition to AA, have come up and sprung up to meet the needs of other people. So this is good news. I'll just end with this resource. This has really improved a lot in terms of finding more about alcohol use disorder, all the things that I've been talking about. You can do screenings, self-screenings here on the website. It's a government agency. It's the National Institute of Alcohol Abuse and Alcoholism. There is this alcohol treatment navigator you can see here, and has a ton of information. So please tell people about it, spread the word. It's kind of an easy go-to place to find out more about your own alcohol use if you're worried, or somebody else's, or find out how to help somebody who has an alcohol problem. So I definitely recommend that website. And thank you for having me, and look forward to the questions. Thank you.
Good evening. Great to be here in Needham. I grew up next door in Newton. Left for 35 years. Very happy to be back in Massachusetts. Needham to us was always the Calvert factory. My mother was raising 5 children in a suburb that my parents couldn't afford. And so she only shopped at the Calvert factory and at Filene's basement. And my brother did once ask her, "Mom, is irregular a brand name?" So, great to be back in Massachusetts. I'm going to talk about this report that I did. I want to thank my research assistant, Shishi Jo, and the many other people in Massachusetts who shared data and insights with us. My job tonight is really to bring this home. What does this look like in Massachusetts? What does it mean for those of us in Massachusetts? Why did I do it? I've worked on this issue all over the world in pretty much every place that you can imagine. And then I came back to Massachusetts. And I watched what was happening. I listened to the conversation. I read the Globe, etc. And over again, alcohol, when it was discussed in Massachusetts, it was discussed as a business story and not as a public health story. Some other states have something called a State Epidemiologic Outcomes Working Group, a SEOW. These were once mandated for all 50 states. We apparently don't have one for Massachusetts. It's a place that is supposed to pull everything together, so I did that. Data can help us to tell the alcohol story, can put alcohol policy in context. The state has lots of data about alcohol, but it's spread out, it's dispersed all over the place. And so my goal in the report, our goal was to bring it all together in one place and then provide a platform for a more robust conversation about alcohol policies and public health than the state was actually happening, to base it in data rather than in anecdote and myth. So congratulations, Massachusetts. We are definitely above average in terms of our alcohol consumption. Nationwide, surprise, surprise, the bulk of the alcohol is consumed by the heaviest drinkers. In fact, the heaviest drinking 8% of the population consumes more than half of the alcohol. Here in Massachusetts, similar skew. About 40% of our residents actually didn't drink in the last month. And of those who did drink, 44% were the binge drinkers. They account for the majority of the alcohol we consume. We are among the top 10 states for binge drinking. You've already heard from John, 140,000 deaths a year. Just on the right of the slide, binge drinking responsible for more than 40% of the deaths and 3/4 of the costs attributable to alcohol misuse. So let's think about these binge drinkers for a minute. It's great that you got all that information about treatment and how well treatment can work. According to a New Mexico study, 92% of the binge drinkers will never qualify for a dependence diagnosis. They will never show up in treatment. So if we're going to make headway on this issue, we need to use other levers than just treatment. Treatment is absolutely the ethical responsibility of a society that makes addictive like drugs like alcohol so widely available. But we will never treat our way out of this problem. Here in Massachusetts, this is snapshot 2019, over 3,000 deaths, about 1 in 20 deaths, 110,000 years of life lost to death and disability due to alcohol use. Those are called DALYs, disability adjusted life years, and life years, and those have increased by almost 14%. In the past decade, with that share rising faster than that of lung cancer, diabetes, high blood pressure, dietary risks, or tobacco use. I'm all good news. This is average. These are figures from CDC. The average over 2015 to 2019, again, a steady kind of 2,800 deaths a year. But look where they're coming from. They're coming from poisonings, alcoholic liver disease, alcohol-attributable cancers, liver cirrhosis. These are the leading categories. What's not in that? Drink driving deaths. And yet that's the only problem you ever hear about. Drink driving deaths are less than 10% of the adult deaths from alcohol. We have a narrow conversation about alcohol and its consequences. For young people, the crashes are number one, followed by poisonings and homicides. I'll talk more about those in a few minutes, or maybe now. In 2020, 148 alcohol-attributable suicides. Those are the ones we assume would not have happened if alcohol hadn't been in the picture. 99 alcohol-attributable homicides. CDC estimates 47% of homicides would not have happened if alcohol were not in the picture. 55,000 alcohol-related emergency room visits. Talking about those visits, it's close to 2% of the total ER visits, but it's also what my friends in the emergency rooms call frequent flyers, in that we are number one, alcohol abuse and dependence, for emergency room readmissions, the largest single cause in 2021. 23% of alcohol abuse and dependence admissions were followed by a readmission. 34% of alcoholic liver disease admissions followed by a readmission. Treatment admissions, yep, alcohol, our favorite drug. 72,000 diagnoses of alcohol-related use disorders, the most common behavioral health diagnosis in Massachusetts, and also has the longest average length of stay. Now we get to drink driving. Yes, here again we are above average. The national average, 28% of all fatal crashes. Here in the Bay State, it's about 32%. 98 deaths from those crashes in 2020. Approximately 66,000 adults in Massachusetts self-reported having driven after drinking in the past 30 days. We care a lot about young people's drinking. If we really care about that, we have to care about adult drinking, because one of the largest predictors of a young person's drinking is the drinking of the adults around them. We found this over and over again at the state level. And alcohol policies, the mix of policies that we use to control alcohol use, are a major factor in the level of risk that our young people face. And I have colleagues who have scored the whole basket of policies according to the weight of the evidence behind them, how effective we think they are. The higher score means your state is more restrictive, more in line with the public health research. A 10% increase in that policy restrictiveness score is associated with an 8% reduction in the odds of young people drinking. 7% reduction in the odds of young people binge drinking. The bottom line, the states with stronger alcohol policies for everyone have less youth drinking. And our alcohol policy score is the 17th among the 50 states. We have room for improvement. In terms of our young people, yes, they are above average as well, perhaps even more above average than our adults. 24% drank alcohol in the last 30 days, 15% binged in the last 30 days. We are number 6 in terms of prevalence of past month drinking and past month binge drinking among our underage youth. During the pandemic, there were a number of surveys done, and it was clear that things were happening. Even prior to the pandemic, the first 20 years of this decade, things were getting worse nationwide regarding alcohol. The alcohol-specific death rate up. The rate of emergency room visits up by 47%. The age-adjusted death rate for alcoholic liver disease, a kind of canary in the coal mine, up by 47%. And then during the pandemic, again, lots of reports that various segments of the population were drinking more during the pandemic, and we did all sorts of things to loosen alcohol availability during the pandemic. Carry out cocktails, home delivery, what they call in California parklets, what you see in the North End, permitting establishments to greatly increase their square footage so that people could have food, drink, etc. in open air, places where COVID-19 transmission would be less likely, but at the same time, a major increase in alcohol availability. And look what the early data show: deaths involving alcohol up, age-adjusted death rate up, with the largest increase happening with the young people who really are at the peak of their productive years, the 35 to 44-year-olds. And what do we know about what happened in Massachusetts? 3 out of 5 adults self-reported they used at least one substance in the last 30 days. Among the substances they reported, alcohol was the most commonly used, and 38% of the adults surveyed said that they were drinking more during the pandemic. Need to talk a little bit about inequities. The consequences of alcohol use are inequitably distributed. This is most obvious worldwide. Worldwide, men do the bulk of the drinking. Women suffer a disproportionate share of the consequences. Everywhere in the world, what we find is the same amount of alcohol in a poor family, community, or country, for that matter, will cause far more damage than in a wealthier setting. What we know from our surveys, white people drink more than African Americans, Hispanics, and Latinos. They binge drink. American Indians and Alaska Natives drink and binge drinks at roughly the same level as white people. For all 3 of those groups, the risk of health consequences from alcohol is much higher. Alcohol dependence, liver disease, alcohol-related cancers, involvement in alcohol-impaired driving, interpersonal violence, all of that. According to one study, alcohol use alone explains as much as 27% of socioeconomic inequalities in mortality. So what do we do? The World Health Organization has looked at all of public health. They have a whole unit that does effectiveness and cost-effectiveness studies. For alcohol, their 3 best buys, the most effective and cost-effective measures, are to strengthen the restrictions on availability, enforce bans or restrictions on alcohol advertising, sponsorship, and promotion, and raise the price, usually through excise taxes and other pricing policies like eliminating discounts. Thank you, Massachusetts. We still don't allow happy hours. We are not the only state. 6 states do not have happy hours. The advisory body to the Centers for Disease Control, again, 3 of the things they asked to emphasize: increasing taxes, maintaining limit on days and hours of sale, and regulating alcohol density. So in this report, I wanted to look at not only what the problems are, but where is Massachusetts on WHO's 3 best buys. So let's start with availability. And here, the media coverage is ridiculous. It is all the alcohol industry saying, we don't have enough licenses, we don't have enough licenses. We're a puritanical state. If we just, set this whole business free, as John said, all the problems would go away. Well, that's what we've been doing. The problems haven't gone away. In the last decade, the number of active licenses in our state grew by 63%. In terms of off-premise licenses, package stores, we have nearly 3 times as many liquor stores as we have Dunkin' Donuts outlets. In terms of states that limit the number of off-premises licenses, there are 16 states that sets limits. We have the 4th most generous allowance. We have about 5 licenses per 3,000 population for bars and restaurants. Compare this to the limits that New Jersey sets, that Pennsylvania sets for bars and restaurants. We have 5 times the limits that are permissible in those 2 states. Advertising and marketing, I ran something called the Center on Alcohol Marketing and Youth at Johns Hopkins for 15 years. We looked at things that states were actually doing to reduce the likelihood that young people would be exposed to alcohol marketing. There are 8 potential things that states could do. Massachusetts does exactly one of them. Again, we have potential. Alcohol taxes. This is so sad. Our taxes are a flat tax. They're based on the volume in the beverage. The volume in the beverage doesn't change year to year. So every year that there is inflation, this industry gets a tax cut. which is virtually every year. What that means, since our alcohol taxes were last raised and left in place in 1980 when Jimmy Carter was president, they've lost 72% of their value. And that right-hand column shows you what they would be now if they had simply kept up with inflation. This is why one of my colleagues in Texas calls alcohol taxes a poorly performing revenue source. This is the percent of Massachusetts tax revenue that comes from alcohol over time, and you can see it just drops steadily at the same time that the alcohol problems have been going up. And the revenues fall far short of alcohol's cost to our state. Per capita cost of alcohol problem, the last study that was done that looked at state level costs was 2010, was costing all of us about $861 per year. $345 of it came directly out of our tax dollars, paid directly by government. The revenue coming in from alcohol excise taxes to state government, $11. If you look at this at the tax and cost per drink in Massachusetts, our tax on alcohol is a nickel a drink or less. If it were adjusted for inflation, it would be closer to 18 cents a drink for distilled spirits. And again, per drink consumed, alcohol generates $1.93 in social costs. Government pays 77 cents. Government gets back a nickel or less. You hear over and over again, well, we're so puritanical, we're Taxachusetts, etc. We're out of date. We're certainly out of date in terms of our taxes keeping pace with inflation. And no, we are not more restrictive than the other states. We have lower taxes on alcohol than the rest of the New England states, with the exception of New Hampshire on distilled spirits. And we know exactly what New Hampshire is doing with distilled spirits. They're trying to get people in Massachusetts to cross the border and buy them so that New Hampshire residents don't have to pay an income tax. The current status, this is kind of a ritual in Massachusetts. Every year there are bills to raise our alcohol tax. They are incredibly modest bills, and I know they're modest because I pushed the perennial sponsors this year. Couldn't you go for something a little more ambitious? No, they are what they are. Rep. Khan's bill basically doubles the existing tax, which doesn't even make it keep up with inflation from when it was last set. Jason Lewis's bill similarly raises it about the same amount. I don't really care in a certain way how much they raise it. Any amount that we can raise the alcohol tax. The research is very, very clear here. There will be public health benefits across the board. And oh, by the way, it raises more money. And that more money can go to all sorts of good things. I was a key part of the effort in the state of Maryland in 2010 to raise the alcohol tax there. We failed to get an increase in the excise tax. In a certain way, we got something almost better, which is we got a 3% special sales tax on alcohol. And the nice thing about sales taxes is they rise with inflation. So when it was first passed, it was raising about $70 million. It's now raising more than $130 million a year. And I'm so proud when I go to Maryland, because if you buy alcohol in Maryland, you get a receipt and it has alcohol tax 3% on that receipt. That's my line. We have these two bills. These are the people who will make the decision about that. They work for us. In conclusion, this is a product that causes significant problems and costs in our state, and the revenues from alcohol come nowhere near covering those costs. Making alcohol cheaper, for instance, through discounting ladies' nights or letting happy hours come back, will make things worse. We have no shortage of places to buy or consume alcohol, and many more than comparable states. We do little as a state to reduce the likelihood that young people will be exposed to or influenced by alcohol marketing. There is much more that we could do to save lives, protect young people, and make Massachusetts safer and healthier for all of us. There is a resolution that we have, and if you want to take out your phones and take a clip of that QR code, this is something that organizations can sign, coalitions, etc. It is not lobbying. It's a position statement. Doesn't mention any specific bills. It's simply saying, because all these things are the case that I've talked with you about tonight in Massachusetts, therefore, we think our alcohol tax should go up. Simply a position statement. We did one of these in Medford. We had 3 city councilors at the forum that we did, and I'm looking forward to and hoping that the Medford City Council will sign this resolution. For more information, more QR codes, Liz is going to talk about MAPC. I'm going to shamelessly promote my report. There are more copies of it on the back table. Thank you so much for coming tonight. Thank you to Carol and everyone that has made this possible. I'm cheering you on for everything you're doing in Needham.
Wonderful.
Thank you so much, Carol and Tim, for having me this evening. It was so great to see some old friends and some new ones as well in the audience. My name is Liz Parsons. I am the volunteer chair of the Massachusetts Alcohol Policy Coalition, and that's the capacity in which I'm speaking with you this evening. I do also have a day job working to support the states and local community coalitions as they work towards implementing effective alcohol policies, and I'd be happy to speak to you more about that afterwards if anybody would be looking for some support. So there are, for those of you who don't know, over 200 community coalitions in Massachusetts, and they've been working for years on underage drinking prevention. We've got the legendary Lynn Frano in the room, you all know Carol, and there are many more across the state. So we are absolutely thrilled to have this report at our hands and this data available. And before I say more, I want to take a second to just, for everyone here, we're all in this for a reason, and many of us for personal reasons, and it's important to reflect that alcohol is no ordinary commodity, and yet it's very much treated like one. This is a Boston Globe article. Headliner, most anything we do these days comes with a drink. Many of you are familiar with some of these scenes and sites. Just today, someone sent me the ad for the opening, this is tonight's opening night. You said alcohol was man's, oldest friend?
An oldest enemy.
An oldest enemy, and dog was a man's best friend. Well, there is a dog park bar opening up in Everett this evening where you can bring your dog and have your drink. So we've heard all the reasons why we need to act. It's our collective responsibility to protect our youth from harmful substances like alcohol. And in some way, and we do that in the same ways that we do for other drugs and harmful drugs that have more of a stigma for use than alcohol does. So I just want to ground us a little bit in the policy discussion that I'm going to speak about. When there are so many efforts to change alcohol laws and regulations, I think it's important to remember why we regulate alcohol and what's the purpose. First and foremost, alcohol regulations, they always have been for public health and safety. And that's the core, pillar of alcohol regulation. It's also there to ensure effective tax collection and to eliminate unfair practices or illegal marketing practices. So we'll talk more about that in a second. And then just basically to try to balance the various competing interests, both from a public health standpoint, but also from an economic standpoint. Who here has heard of the 3-tier system? Yeah, okay, yeah, you guys, good. So the 3-tier system is the way in which alcohol has been regulated since after Prohibition. So the top tier, you got your producers. You'll see here some popular ones, but this is also be like your local craft brew that anybody who may manufacture or produce. And then the second tier is the wholesaler. So those are like the big companies, distribution companies, who push out who are responsible for collecting the taxes and also paying the taxes and pushing out the products to the third tier, which is the retailers. The important part of this regulation is that they're all separate to do exactly what I just said, protect health and safety and do all these measures, prohibit price wars, monopolies and things like that. This is not what our three-tier system looks like today. This is what our three-tier system looks like today. Any of those look familiar, people? So Amazon, what would Amazon be acting like? A retailer and a wholesaler, because they, can distribute the alcohol and they can sell it to the consumer. We got Drizzly, which is Boston-based. They also deliver. And then this doesn't even, Costco, huge wholesaler, being a retailer. I mean, this doesn't even account for your Uber Eats, your DoorDash, who are doing home delivery sales. That's a whole other presentation. But our ABCC, our Alcohol Beverage Control Commission, is doing an outstanding job of holding them accountable for their illegal deliveries to underage youth. Okay, so when looking at what works in excessive alcohol use and underage use, we've heard it here from all of our panelists, and David pointed them out as the best buys: price, promotion or advertising, place, the outlet density, the availability, accessibility, and then here I've added the product as well, which also could be the promotion, or you talked about the toxicity, and so we're thinking about like alcohol beverage content, things like that. So the product, there are examples here. We've got champagne gummy bears, spiked whipped cream, alcohol-infused ice cream, non-standard products, right? Other states might have powdered alcohol, or soon to come in Massachusetts potentially is sort of the ready-to-drink or liquor in a can, Jack and Coke, or mixed sodas and alcohol. That's also another presentation that David would love to give, I'm sure. Price is a huge one, as we know. Just increasing the price is going to decrease underage drinking. Youth are very price-savvy consumers. We get a lot of questions about NIPS, and I thought David answered that really well, where price point would be an important consideration when considering banning NIPS for youth. Outlet density, how many places can you get alcohol, how close are the outlets together? I'm going to talk a little bit more about that. For local action, and then advertising. The more alcohol ads kids see, the more likely they are to drink. So what can local communities do to help regulate in these spaces? Some examples here for decreasing alcohol affordability and increasing price. David talked a lot about the statewide efforts around alcohol tax. Absolutely, that would support our local communities and reduce underage drinking. Eliminating happy hours. Massachusetts, yes, does not allow happy hours. However, it could be a nice protective policy put in place in communities. If you see that coming down the line, discounting, eliminating bulk discounts on pitchers. And then the other price point that local communities could think about is licensing fees. So you could increase the cost of what the license has to pay to the city or town to fund compliance or other efforts. To reduce physical availability, and I know from Tim's opening comments, this was a hot topic in Needham not too long ago, 48 hours ago. But obviously reducing the spaces and places that people can drink is crucial and important. The types of outlets. I just had a call from a community the other day saying they were having an ice cream vendor, local ice cream vendor, show up at they wanted them to be at their community event. They were also selling alcohol-infused ice cream. So what could they do in that situation? And so, yes, there is some law that would, require them to look at the actual product to see what the ABV is. But there's also, could be other things that they could put in place to restrict those ice cream vendors being in community events or community spaces. Bans on underage patrons in the bars, bans on products. Like alcohol energy drinks or the ice cream, things like that to consider, and then hours and days of sale. And then lastly, the third of the best buys is advertising or promotion. Thank you, Dr. Kelley. And this is, some communities in Massachusetts have done this and done this very successfully. And, you know, those of you who worked in tobacco, you know there are some restrictions on the exterior facing and alcohol ads around premises. The same could be true for alcohol. Restrictions on billboard advertising, bus shelters are often on city or town property, telephone poles, and potentially ice cream truck vendors, to go with that theme. But the other thing I just wanted to say about this other one was just be thinking about a lot of times the communities will talk about responsible beverage service or social host ordinances or sort of changing the drinking context. And those are efforts in our communities and our coalitions that we often, really work with and think that that's sort of the gold standard. It's there's what's called insufficient evidence for it being effective on a population level. However, we know as coalition coordinators that can help build some momentum and some support for other potential, more impactful policies. Okay, so what can local municipalities do? Get your local data. Use this Massachusetts report, certainly, absolutely. But, start lining up your partners for, your police departments for calls for service. Alcohol is often not listed in certain calls because it's not an illegal drug. So oftentimes police departments won't even put that on any report. So when you're starting building your relationships with police officers, that's something. If you don't have that, don't let that stop you, because there's certainly tons of data available, but that's one idea. And another goal for our municipalities and our boards of health and our coalitions is to really work to center public health in the conversations around alcohol regulation. As David said, it's been a business issue, locally and statewide. We know that. But public health is also a business issue. We want economic viability in our communities too. It doesn't, just because we want to center public health does not mean we don't care about the thriving of our businesses thriving in our community. So this could look a couple different ways. You could have a liaison, a public health liaison, from your Board of Health or from your coalition who attends your local liquor authority. For Needham, it would be your select board, is that right? Yeah. Or a select board member becomes the designated alcohol policy liaison or liaison to the coalition where that communication is happening. Maybe institutionalize a yearly educational piece for your local liquor authority so they understand the public health impacts. One town that I'm working with is looking at an alcohol sort of advisory group or maybe even commission, so it's institutionalized in the city. So you can have experts on an advisory group who are always, would look at any or review any alcohol regulation change. Health impact assessments are another key ask that you could look to ask for. And with any policy, you always want to think about building compliance. So you finally get the policy of your dreams happening. Is it really, taken into effect? Is it really being applied in your community and enforced? What can what can coalitions do? Well, we've got the two major coalition leaders in the room, at least that I know of here, so you can certainly talk to them. Some of the things that I've learned over the years, staying connected to the entities, both nationally and statewide, for the advocacy and increasing awareness. For those prevention specialists in the room, those who are doing this for their jobs, we are ethically responsible, and it's our ethical responsibility to lobby in our personal time, in our personal lives for these impactful policies. Really understanding the enforcement issues, supporting our Alcohol Beverage Control Commission, and leaning on them as well. They will come and do compliance checks for you. If you have a problem, licensee, if you have intel on how youth are getting alcohol in your community, the best thing we can do is support our ABCC and really work on that, building that compliance for our communities. Locally, there's a big list here. One thing I will say is that youth and pediatricians have major influence on people's views and attitudes about these issues. So they are our best. Youth and pediatricians are our best messengers around alcohol harms and solutions that we're talking about tonight. So I really encourage you to build up the capacity of your youth in your towns. I think that's it. What will you do? I also have the QR code for that resolution in case you missed it before. Thank you so much. Please feel free to reach out if you have any specific questions or would like support in your community, for your community coalition or town. Thanks. I forgot my products when I was doing advertising. These are show and tell. Some of these are alcoholic, some are not. Do you know which ones? One's alcoholic, one's not. Right? This is Arizona iced tea. This is an IPA. This is just an example of the marketing. This is a sour ale, Warheads. Are you familiar with Warheads? It's a candy. Yeah. You can come up and have a look if you guys want. And then people are very familiar with Twisted Tea, I think, see that and the sort of the look of it. This is just an energy drink made to look like Twisted Tea, and it's got Sour Patch Kids on it. So we talk about advertising to youth and youth-friendly. Can you imagine a hard Mountain Dew in a store? Like, what are kids going to think about that? Yeah. That's it. I'm done. Thank you, Kim.
Thanks, Liz. So thank you very much to our panelists. We did want to ask a couple questions before we turn it over to the audience. And I guess I'll start with David and Liz, and maybe use the recent meeting example. So Liz, you talked a little bit about trying to get public health centered in the conversation about economic development. But can you talk a little bit more, maybe David and Liz, about how you get a select board, for example, when Needham made a decision to ban tobacco, the decision was entirely within the control of the Board of Health. The Select Board, the Planning Board, other town elected officials raised concerns, were very concerned that businesses would close, there'd be terrible economic impact, but the decision ultimately rested with the Board of Health. When we're talking about expanding alcohol outlets, both on-premise and off-premise, the Select Board is the decider in this instance, now that the town has granted the Select Board the permission to add alcohol licenses. What is the way to combat this is the best way to attract people to our community? Restaurants need a liquor license in order to be economically viable. We need to have, a cluster of restaurants in order to attract diners. Tell me, I guess, a little bit more about how a community coalition can push back against that argument.
You want me to go?
Yeah, go.
Okay, thanks for the question. I think of this on two tracks, a technical track and an organizing track. And let me talk about the organizing track first, which is that politics is about who you know. And the best way to influence a political body is to figure out who you know on that body, or who you know who knows somebody on that body. People are most willing to believe people that they know. So this is an organizing issue, and it's one-to-one. It's getting out of our comfort zone. It is spending that time, and I just spent 3 hours this morning with 180 prevention folks from Maine, pushing them out of their comfort zones, saying to them, look, if we're going to change the culture around alcohol, if we're going to change the world around alcohol, it's got to start with us. Nobody else is going to start those conversations. We have to start the conversations. So that's sort of my generic answer to the issue about the select board here in Needham, is the conversations need to happen. And they need to happen wherever you are. If you are in a church, churches are great places to have these kinds of conversations. If you're involved with the Y or the Boys and Girls Clubs or whatever, these are other great places. If you're in the garden club, whatever the things you do that give you opportunities to interact with other citizens, other voters in Needham, those are opportunities to have this conversation. And I will tell you, I don't ask people to do things that I don't do myself. And regularly when I start these conversations, it's about a half an hour of Q&A. Because people are so hungry for more reliable information that makes the world make more sense to them than what they're getting all the time, which is this is everywhere and everybody should do it. So that's the organizing piece. The technical piece, I'm a big fan of health impact assessment. And if you can get your licensing body, your select board, whatever, simply to say, that's great, the citizens passed this. When you actually start issuing licenses, though, it's really important that we have a health impact assessment. And this is a great training if you're looking for people to do this. We train public health students to do these. My favorite story about this is Baltimore, where I lived for 10 years. And talk about community problems, Baltimore has plenty. We also, as a city, had twice as many alcohol outlets than the supposed state cap. It had just happened over time. And the city decided to reform its zoning code for the first time in 40 years. A group of our students at the School of Public Health decided this would be a great opportunity to learn about health impact assessments. So they did it. They looked at zoning. They looked at Baltimore. They looked at the problems. They were not trained in alcohol policy at all. They stumbled on alcohol as the obvious thing in terms of zoning. And as a result of their work in that zoning code rewrite, there were 3 provisions that were specific to alcohol that have removed retail signage across the city, that have eliminated at least 100 of those outlets. There's great potential there.
Great, thank you.
Liz, did you want to?
Oh, sorry. I don't want to add anything right now, no. I've lost what I was going to say.
Okay, that's okay. The next question, I guess, maybe is a little bit more in Dr. Kelley and Amy's sort of wheelhouse. The argument that, not necessarily the rite of passage argument, but the argument that you'll hear from some people that binge drinking rates are not the same in Europe, use rates are not the same in Europe, and if we just give, 12-year-olds a little taste of wine at a couple meals, that everything will be fine. What's sort of the pushback on that?
I'm ready with an answer.
I know. I've heard David answer
Okay,
this
good.
before, so I'll simply say that as part of my prior professional life, I interviewed key thought leaders from around the world, and I asked this question of alcohol addiction specialists in Europe all the time, and they said this is the #1 myth that Americans have, and they said we have a terrible problem with youth drinking, with alcohol addiction is rampant. And so please, try to dispel that myth in the U.S. So I'm doing my part, but I'll let David go ahead and.
John, did you?
Yeah, one of the things that, again, alcohol addiction rates are also extremely high in Europe. Also, alcohol toxicity levels. France, for example, a big wine drinking country and producer, has one of the highest rates of liver disease in the world. So again, it's not just about alcohol addiction and intoxication-related harm. There's also toxicity-related harm that is associated with alcohol and liver disease. The rite of passage, that is culturally determined. When you look at cohorts, when you look actually from 1900 to 1950, we think today, I think culturally, that adolescents and young adults are kind of like, they're pre-programmed. They're pre-programmed to just drink, drink and use other drugs. It's kind of inevitable. It's like Mother Nature intended it to be that way. But when you look at rates of use among 12 to 25-year-olds between 1900 and 1950, it's the lowest rates of use in that age group. Right? After 1960, the rates go up, use before age 15 in particular. And concordantly, you had tripling of the rates of alcohol use disorder in women born after 1950, lifetime rates, and doubling for men born after 1950 for lifetime alcohol use disorder. So again, it's culturally determined in terms of how we. It's not just a developmental process. Yes, there is, as Amy was talking about, there is a propensity, of course, for natural risk-taking in adolescence and as they emerge from the nest. But it doesn't have to mean that they have to be using drugs, including alcohol.
This is the most common question I get. We have comparable surveys of 15 and 16-year-olds in the U.S. And in more than 30 European countries. Same questions asked in the same settings. Those survey findings in terms of prevalence of alcohol use among our 15 and 16-year-olds, we are second from the bottom. What 21 does is it delays the age of onset in this country, and that is incredibly helpful. The only country lower than us is Iceland. They have a purchase age of 20. Now, if our young people drink, then they tend to drink heavily because they copy the adult drinking pattern. And we have a Northern European drinking pattern. We drink like the British, the Germans, and God help us all, the Scandinavians. So in terms of binge drinking, if our young people drink, we're more in the middle of the pack. But 21 is clearly protective of our young people in terms of age of initiation, and John and Amy have talked about how important that is in terms of long-term health, brain development, all those good things.
Thank you. I'd like to turn it over to the audience. Any questions for the panel?
Yes. Thank you, Tim. I have a couple questions. I'll just do one for now so other folks can have a chance. But something that I've been thinking about lately is social media. We're kind of looking into social media more. And I was wondering if anyone knows much about the regulations on advertising on social media, if they're state specific, if they kind of cross the lines. Like, for example, could an 18-year-old be fed an ad on social media for some type of alcohol? Could they be seeing that ad in Massachusetts and not in other states? Could it be the same across the country?
That's a great question, and I wish very much that we had a better answer. All research on alcohol advertising and marketing in the U.S. funded by the federal government stopped close to 10 years ago. There's been enormous change and movement around social media since then. Our main research body is very close to the alcohol industry itself. And we actually have a Freedom of Information Act request that got an email from the head of NIAAA promising the Distilled Spirits Council that they wouldn't do that kind of research while he was the head of NIAAA.
Really?
CDC has just let bid for proposals for somebody to start looking at how we could monitor young people's exposure to alcohol marketing and social media. It is very challenging. It's more expensive than anybody wants to pay. My general statement about it is the wild, wild west without a sheriff. It is entirely self-regulated. There's a tremendous amount we don't know that's happening. Our friends in Australia have looked at, during the pandemic, they looked at one Friday night for an hour on Facebook and Instagram. There were 35 ads. No, there were One ad every 35 seconds is what was being served. And this is geographically targeted, contextually targeted, behaviorally targeted. It is much more effective. There's much less waste in digital and social media marketing than there is for traditional marketing. And the last story I'll tell is I'm part of the Global Alcohol Policy Alliance. We do a big conference globally about every 3 years. We had our last one in Dublin, Ireland in March of 2020, just before all the lockdowns. There was a group of 15 young people from Texas, from a DARE group in Texas, who came to that conference. They landed in Dublin, and they started searching Global Alcohol Policy Conference on their cell phones, and they started getting served alcohol ads because somebody had bought the word alcohol in Google searches. So the direct answer to your question is yes, absolutely. Young people can be served. Young people are being served. We're getting all sorts of stories from people. Your kids are watching some great old movie on YouTube, and it's preceded by alcohol ads. There is no sheriff. It's entirely self-regulation, and we don't really know what's going on, and that's a big problem.
I'm one of the people that attended to testify at the select board meeting using your report that we cited multiple times, and we had a formal letter. I feel like late in the process, and we're an advisory board, and we all have day jobs, and we meet once a month, and we have so many issues that we work on, and I guess I don't know how to keep our foot on the gas when it's a topic that our board sees. I mean, we do talk about it every month, and thank goodness we have good staff that run this, but I wish we had gotten involved earlier on the review, and perhaps we could have had a little more traction. I mean, the vote wasn't a landslide by any means. I think people see some of the issues, but getting some of this information out more widely would have been beneficial, I think. So that's all.
Well, all I can say to that is to absolutely cheer you on. In so many places we're late to the party. One of the stories I like to tell is the tax cut on alcohol that was passed in 2017. We were trying to keep it from being made permanent in 2020. So I and a guy from the Consumer Federation of America went to meet with Nancy Pelosi's top tax staffer. And the staffer listened to us very politely for about 15 minutes, and then she looked at us both and she said, "You guys are great. You're great. You've got great data. You've got great information. Where have you been? My members hear from this industry every single day. Where have you been?" So you're not alone in this. This is a massively underfunded effort. I'm thrilled that Needham can pull down any federal dollars that they can, but you look at what happened with tobacco. Robert Wood Johnson Foundation put $700 million into tobacco control work. They've not put a penny since 2000 into alcohol. Nobody else in the philanthropic community wants to touch it. The best thing I can say to you is be a nuisance. Be a Carol Reed. Be an indefatigable and undefeatable. I'm so pleased that you did get to the party. And there's a lesson there in that this is a party that's happening all the time from the industry's perspective. And I know we're doing this in our spare time and volunteer, etc., but we got to be at the party.
Shannon, I work with Carol Reed and Lydia and Karen Mullen in the Public Health Department on youth substance use prevention. I'm also the person who oversees our community coalition, SPAN, the Substance Prevention Alliance of Needham. And tied into our work very closely is our high school program called SALSA, Students Advocating Life Without Substance Abuse. And if it wasn't for Karen Mullen's indefatigable perseverance with those students, we wouldn't have such a robust program. I'm very grateful to her for her many years of work. My question is, one of you had commented, and pardon me if I haven't identified you properly, but that our best promoters, our best spokespeople are our youth and pediatricians. So thinking about the youth message for a moment, what would you recommend well, two questions. How can we best develop our youth and their messaging? And what would you recommend as some of the best places to bring them in front of? For example, we went to the State House last week for Kick Butts Day. We had 17 students from salsa there, and which was impressive. And we were able to get meetings in front of two of our legislators. So I'm just curious with alcohol and how we can leverage the youth voice, and any advice you'd have about that.
Thanks for the question. Yeah, that was me. That came from research. That was from the Frameworks Institute. If Lynn Frano knows, she hosted the training. So there is a sort of anthropological, social psychological research about that. So that's backed that youth and pediatricians are most effective messengers for substance use prevention. And I have experience working with youth coalitions in Boston. That's when I met David years ago when we were looking to ban alcohol ads on the T. And so I think the best thing that you can start, when you're working with youth, and it sounds like you've developed great relationships and a great group, is to train them on the issues, train them on the best buys. They're doing Kick Butts Day. They know the issues in tobacco. They're easily translatable for alcohol. And also listen to their experiences with it. Their social media, on advertising, where they know where the kids are. They know, where they're getting their alcohol. They know what the issues are. I've got one town I'm working with. They want their youth to go in front of their school committee first. So when you say what spaces should they be in front of, once you train them and all those youth development type things, their elevator pitch, their public speaking, whatever, all those elements, then put them in front of the decision makers. That's where they're going to be most effective. It's very difficult to say to a group of young people who know their stuff, who've done their work, who are showing up with the data and with the anecdotal data and with those qualitative stories. It's very difficult for them to say, oh, actually, no, not this time. And, for the ban of alcohol ads on the MBTA, a little bit of it, a ton of it was just the youth showing up every decision-making meeting. You as an adult coordinator need to know where those spaces are in those decision bodies and let the youth know. I would put them in front of those decision makers, and you could also, in front of the public as well, or the other voters. Anybody else have anything else to add?
I just wanted to ask, tying into that is our pediatricians, and many of us over the years have gone and spoken to our pediatric offices in prevention, and I'm wondering, probably Dr. Kelley and Amy, we were at Westwood Pediatrics, Dr. Lester Hartman, a huge advocate for tobacco prevention, but they shared freely, they don't get the education, and they would ask you about if you have a trampoline during your child's visit, does it have a net? But how do we get our pediatricians to be more comfortable, more camera ready, to be next to our youth, to be next to us? I feel like it's a huge missed opportunity, especially having such huge trust in my child's pediatricians for many years for other issues.
Well, my thought was you just need one, and maybe it's David's tactic of relationships, like who knows, somebody, I think, if you have one champion pediatrician who can be that spokesperson and be, in those decision-making spaces as well, or be quoted in the media, then, that's great work. Your comment about, maybe having a larger movement in the healthcare, for healthcare providers in having those conversations with youth, that's another sort of internal organizational policy, effort.
I'll just add that the American Academy of Pediatrics is very supportive on the alcohol issue. They were one of our key partners in getting the STOP Act through. Many of you are familiar with that. That's the only piece of legislation that Congress has ever passed solely devoted to underage drinking, and AAP was right there with us. So that's another resource to find pediatricians, is actually to go through the AAP. I also want to go back to the youth question for just a minute, and doing counter ads with young people is so great. It is an excellent form of media literacy training, and they will say and do things that adults are not as willing to do. And they're really good at sort of tweaking adult hypocrisy on this issue. So I've done this in various places. We had a great campaign that a bunch of young people did again in Baltimore. They worked with one of our big art schools and did a whole counter ad campaign taking off on Colt 45 works every time with images like body bags and somebody throwing up into a toilet and all that nice imagery. So that's a great youth activity. I love treating young people as citizens. And I love that you went to Kick Butts Day. There's an amazing group in Dover, New Hampshire, Dover Youth to Youth. And one of the graduates of that program introduced herself to me a couple of weeks ago. I met her when she was 11. And she's now working with the United States Alcohol Policy Alliance. So it's a great way. Yeah. And the last thing I'll say about that is my school does a 2-week program for high school students, an introduction to population health, public health. I teach the advocacy part of it. It's called Population Health Experience. And you might think of seeing if any of your young people would be interested in doing that. That is a summer program, yeah, 2 weeks in the summer.
I wanted to thank all of our presenters and our audience for coming tonight. It's been informative, it's been interesting, and thank you all very much.
Thanks so much for having us.
Thank you all very much for coming. And we will distribute PowerPoints through email. And please give us your emails, and those watching live will make those materials available. It was just an amazing learning experience. So thank you, each and every one of you. Good night.